Good afternoon, everybody, and welcome. I'm Abby Stamp, Measure 110 Executive Director, and I will be assisting with Melinda with facilitation for today's meeting. The Oversight and Accountability Council welcomes and encourages community input. Members of the public are invited to submit public comments or get on our interested parties email list by emailing oha.measure110@oha.oregon.gov, and like magic, that will appear in the chat for anybody who wants to grab that. That email address and more information about the council can be found on the Measure 110 OAC website. OAC members have asked that OHA and other staff who are present in the meeting space introduce themselves in the chat. Please share your role with the agency, and if you are a subject matter expert, your area of expertise, and I'll now turn it over to Melinda for opening remarks.
Hello, good afternoon, everyone, and welcome to the Measure 110 Oversight and Accountability Council meeting for November 20th, 2024. Today, we will be talking about OHA updates. We have some review panel things to review. We also have to talk about the OAC reappointment. And we also will be doing something with Portland street routes. And going to pass to Hartley for attendance. Can you guys hear me?
Yeah, we got you. Hear you, Melinda. Carly, Carly, you muted?
Okay.
Oh, yeah, I'm muted. I've been talking.
I just say all that?
Sorry. I was going to say, I'm just clarifying that we're going to have a presentation from Portland Street Medicine, not street routes, but I just wanted to clarify that little detail. Okay, Amy, are you here?
Thank you so much for that.
Absolutely.
Yeah, I'm here.
Hi, Amy. Carlos. No Carlos. Caroline?
Here.
Hi, Caroline.
Hi.
Dharma let us know she was going to be absent today. Hubert?
Here.
He's still here. Hunter?
Here.
Hi, Hunter. Jackie let us know that she's unable to be here. She is excused. Keisha? Don't see Keisha. Leticia?
Here.
Hi, Leticia. Linda?
Here.
Hi, Linda. And Melinda?
Yes.
Got you. Meredith?
Here.
Hi, Meredith. Morgan?
No.
Here.
Hey, Morgan. Nicole?
I'm here.
Hi, Nicole.
Hi.
Onisha?
Here.
Hi, Onisha. Ron?
Here.
Hey, Ron. Brian?
Here.
Hi, Ryan. Sabrina?
I'm here.
Hey, Sabrina. Zeb?
Present.
Hi, Zeb.
Hi.
Sam, is she here today? I don't believe so. And Annalise let me know she was going to be about 30 minutes late. And we have quorum. Back to you, Melinda. Oh, you're on mute.
That darn mute button. Okay, thank you. And now we'll pass it over to Abby Stamp for OHA updates.
So thanks, Melinda. Good afternoon, everybody. It's nice to see you all and hear you all. I have a couple of quick updates from the Oregon Health Authority. One is about the panel review meetings. And before I just give an update about that schedule, I just want to give a big heartfelt thank you to those of you who are reviewing the grant applications for the behavioral health resource networks coming up for the new contracts that will start on July 1st, 2025. It is a mammoth, massive task. I just want to say thank you, thank you, thank you for all of the work you're doing to support this amazing work. So with that said, I know it's a lot of work. And so we had to cancel a couple of meetings, giving folks the time they need to be able to complete the reviews. And then we on the agency side will be receiving all of the completed reviews and compiling that information and then having a review panel, the people who review those applications, discuss and make some recommendations. And so we were hoping to meet tomorrow, and we do not have enough information back from reviewers yet to be able to hold that meeting. So that said, if any of you are really struggling, or you're like, oh my gosh, this is a lot of work, or just need to carve out the time, whatever support or assistance we as staff can provide you, please don't hesitate to reach out. I know it's a lot. I totally know it's a lot and it's important. So I appreciate your wisdom and expertise, and also want to have some grace about the amount of work that it is. And at the same time, we need to get this done to be able to have these review panel meetings that you all are going to be able to review that information. Cool. So that's the update on that. I'm very optimistic that we will be able to hold our first review panel meeting next week. Got all my fingers crossed that that's going to be possible. Any questions for me? Yeah, Zen?
Sorry, I couldn't find my hand. I used my real hand. Yeah, I haven't seen information about when batch phase 2 are supposed to be in. I don't know if I missed that or not.
No, we're trying to get phase 1 complete so that we can move into phase 2. And we'll communicate very, very quickly as soon as we're able to move into phase 2. We had hoped to be at that point right now, but we're not just quite there yet. Cool, great. And Morgan.
Hey, that pretty much answered my question, actually. I'm trying to take my little hand down.
Great, thanks. Amy.
When I got phase 2, I thought it said it had to be done by tomorrow. Today, actually. Today is the 20th. That phase 2 had to be in.
Well, if folks are able to do that, that would be wonderful. We know we have not yet been able to have a review panel for phase 1 itself.
Right.
So we want to make sure that folks are able to complete that. So again, I'll make sure that my team is communicating with you all about those deadlines. And my favor back to you, whether it's phase 1 or 2 or 3, just holler if there is any way that you are not able to meet those deadlines.
Yeah, I'm just saying, I was like busting my butt trying to get these in. So if I have an extra day, because we had a death again yesterday, if I have an extra day, I'll take it.
Amy, Amy, you have an extra day, and so much appreciation. Thank you for that.
Thank you. Okay, cool.
Great. Yeah, great. So moving on, pausing. Okay. I wanted to give an update on appointments for the Oversight and Accountability Council, and we've got our Department of Justice colleagues here. We've just, well, frankly, I've been trying to learn about the reappointment and application processes and the timelines. And I just want to be very transparent and earnest about the challenge that is ahead of us. So there are 8 positions, 8 seats, according to law that was passed in 2023, that those members can be reappointed if they desire that. And if any of those members don't desire to be reappointed, we can fill those vacancies by lottery. So if any of you are in those positions, you will have received that communication already. For the remaining positions, all terms expire on January 31st, 2025, which is really soon. And it's probably going to be before we're able to vote, you are able to vote on the RFPs and the grants going out in the next cycle, unless something amazing, miraculous happens, which I've got all my fingers crossed again that we'll be able to do the vote just as soon as possible. And so what that means is that there will need to be an application process. And so we're in the middle of looking back at historical documents and making sure that we post an application on the OHA website that folks from the community can apply and indicate what position they are interested in. And so for those of you whose term does expire in January 31st, we want to go ahead and invite you to reapply, of course. But I just wanted to flag that. I asked really frankly, to our attorney supports, is there any way to extend this? Because that turnover in January would be just challenging. It would be pretty disruptive, and that's simply not possible. And so we will continue to communicate with you all and do everything we can to make sure that this reappointment, reapplication, those processes are done well and done in a timely manner. Melinda.
Hi, so I have a question. I just wanted to know, so like when we first got our assignments for this, I was in question, like, because I work for an organization that it was a residential treatment center for women and children, which was the organization that helps people with substance use or whatever. And throughout the years that we've been on here, I have somehow transitioned to houseless and homelessness. But I think when I originally applied, it was for the person with lived experience. So I'm not sure how you guys came to the conclusion of how the people were put in where they are. But I fit into a lot of different of those categories. And I don't believe I applied for the housing and homelessness in that, but that's where I set because that is the type of work that I do and currently doing. So with that being said, I was just kind of wondering things that were highlighted in blue and set in stone to be reappointed. I don't think that that's very fair or ethical. Just saying.
Thanks for chiming in, Melinda. Shannon, could you help provide some clarity about the legislation that puts us in this position?
Yeah, so Melinda, Shannon O'Fallon from DOJ. So in the letter that went out, right, the 3 categories of seats that were highlighted, Oregon law requires that folks in those seats get reappointed. So it wasn't the Oregon Health Authority that picked those categories. It was the Oregon legislature. And, OHA relied on, my understanding is information that was submitted at the time of application to figure out sort of where everybody is at with respect to the statutory categories. So that's why you see, that's why you each see where you're at in the categories. And again, to be clear, even if you're not in one of the reappointment categories, you can still apply to get reappointed, right? You would just have to go through the application process again. And Amy, I saw that you had a question in the chat. So if you are in one of the categories, if you are interested in being reappointed and you are in one of the categories where there's automatic reappointment, then OHA will take that information, provide it to the OHA director, and then there will be a formal reappointment process that makes it clear sort of what your term is, what seat you're in, et cetera. So, the letter that went out was really more about an inquiry whether or not you wanted to get reappointed, and there will still be another step to complete the reappointment process for those in the automatic categories.
Okay, but just like I said, that we were put in places that we didn't. I don't get it. Like you're saying, these 3 people in the blue category have automatic reappointments, but I never got a clear assignment on. You see what I'm saying? I when I applied for one thing, but I was put into another, the housing part. When I applied for the lived experience because that's what I was up under, was for myself. I believe that I was Measure 110. I have went through everything Measure 110 has implemented, and that's why I wanted to be on the committee, is because I believe so much in this work. It had nothing to do with housing. It had everything to do with helping people not go to jail and get recovery.
Yeah, Melinda,
So somebody on that side put me in a category where they wanted me to be, for whatever reason, is what I'm saying.
Yeah, there are a number of people that fit into more than one category. So I hear you. And I think going forward, right at the outset, I think, the plan is to make it much clearer, what seat you're applying for and then what seat you're appointed to.
Thank you, Shannon. That's very, Shannon and I are talking a lot, making sure it's much more clear moving forward. Morgan.
Is there anything in writing about what seat we were appointed to? Like, I don't think I was ever told. I think we all fit 3 or 4 categories. I kind of assumed which one I was just by process of elimination for what other ones people were filling, but I don't think we ever got told. Am I mistaken?
Morgan, I don't know, clearly, since I'm also trying to kind of understand the process that was engaged in previously. But we are in the, we really need to look at some historical documents and see if there was any documentation to help us understand how that process went through last time. We do have an opportunity because everybody except the folks in those 3 categories that those term ends, we have an opportunity to be much more clear moving forward and really ensuring real transparency and communication about which role folks either have applied for or do or don't want to fill.
Okay, great.
Shannon, anything? Oh, yeah. Yep.
Yeah, no, and just, right, it's my understanding, sort of working with Carly and others, right, that it wasn't made clear in the appointment information that you got back. So, yeah, because we have done some digging.
Thanks for that. And we'll continue to communicate. And if you have anything comes up for anybody after we close here today, please feel free to reach out. I'd be happy to chat. Yeah, Zeb.
Hey, yeah, thank you. So those that didn't get picked to be one of the 8 spots, when they reapply, will the chances be as if they're just like anybody else applying, the same exact process, like when you guys are reviewing applications? Would that be correct?
So you're curious if there's like a weight, either pro or against if you've served previously. I don't think we've made a determination about that. I know there is, I would say that there is value in making sure that lots of different folks in the community have the opportunity to participate, but we have not made any decision about weighting prior involvement. And I would imagine Shannon can speak her own advice, but we definitely want to be lead with equity and ensuring that we're giving everybody the equal chance. Shannon, anything to add?
Yeah, I mean, just from a statutory standpoint, right, there's nothing that would give current OAC members, a leg up, so to speak.
All right, not another thing to bring up. So as of right now, I'm representing Measure 110 on the Opiate Settlement Board. So when the term expires, if that's how it goes, then we need to plan for the representation of who's going to be on that board beforehand and see if there needs to be some type of handoff for that. Thank you.
Good flag. Thank you. Anybody else?
Well, my hand's still up. I guess another thing. So do you guys anticipate since I'm reviewing files or applications, you guys anticipate the reviewing process to be done by January 31st?
Oh,
and
yeah.
the selection process, do you guys anticipate that to be done by January 31st?
Well, I absolutely anticipate all of the review processes and review panel meetings will be done by January 31st. We are in the process of rewriting a timeline that better reflects the workload of reviewing and returning all of these applications to have a better sense of when the OAC will be voting.
Okay.
I don't
Yeah,
have
I'd
a
be
firm
interested
answer
in
on that
an
yet.
updated one because I think like Ron brought up last time, wondering if the people review, I mean, if they're not able to give feedback, we should just try to factor that into the deadline. So
Absolutely.
all right.
Yep. This is the kind of stuff that keeps me up at night trying to think about how we can do this thoughtfully and clearly and ethically with the deadlines that we have to deal with.
All right.
So,
Thank you.
okay. Okay. One last chance, and then I'm going to move us into a conversation with Portland Street Medicine. Okay. I need to first read a call for conflicts. Thanks, Carly. So before we begin a conversation with our burn partner, OAC members with an actual conflict of interest cannot participate in discussions on the matter that presents the conflict. In order to best protect members, we will be calling for conflicts before a matter on the agenda is discussed if the matter could present a conflict for an OAC member. On the agenda today is a proposal regarding funding decisions for current Measure 110 grantees. OAC members may have a potential or an actual conflict of interest regarding this matter. If you announce a potential conflict of interest, you must announce the nature of the conflict, but you can participate in the discussion and vote. If you announce an actual conflict of interest, you must announce the nature of the conflict and refrain from participating in the discussion. And please turn your camera off. If there are not enough members to vote on the proposal, members with actual conflicts of interest will be asked to vote in roll call order until a majority of votes for or against is reached. Oh, I missed my cue. I'm going to turn it back over to Melinda to take us through the presentation, our providers. Go ahead, Melinda.
Thank you. And now I'm going to pass it over to Portland Street Medicine to give us their presentation for their for a budget adjustment.
Hi, can you hear me okay?
Yes, I can hear you.
Okay. Hi, I haven't been here before, but so please, if there's something I need to do different than what I'm doing, please fill me in. My name is Andra Stoll-Carrick. I'm the executive director at Portland Street Medicine. I use she, her pronouns, and I'm talking to you today about a request for a budget adjustment from what we originally requested in our Measure 110 application. Basically today I'm going to give you a brief overview of what Portland Street Medicine or PSM does, some information or background about the original ideas and aspirations that we put into our application, some detail about the proposed changes and why we are requesting those, and then leave some time and space for question and answer. You can hit the next slide. This is our mission statement. We offer our houseless neighbors accessible whole person care to improve and support their health and to bridge a gap in trust between people and systems. This is a picture of one of our teams going into community to connect with people who are experiencing houselessness. You can hit the next slide, please. And this is a brief overview of our scope of practice. Basically, we have teams of people who go out and connect with people where they are, providing some of this basic first aid care for scrapes and cuts, consultation about chronic conditions. We connect with people about their acute medical conditions, sometimes referring them to emergency rooms. We make a lot of referrals. We do not provide, as you can see over on the sort of right-hand side of this screen, long-term primary care, but we do really pride ourselves on the connections and relationships that we build with people, so that we are building trust with them. Many of our patients have well-earned distrust of healthcare and other systems, so we're trying to rebuild that, in part through some transactional interactions like supplies, but showing up time and again, doing what we said that we would do, and providing linkages to other services as needed. We have peers who work regularly with our teams and with our patients. So, like I said, we do not provide long-term primary care. We are not at this time dispensing prescription medications. We can write a prescription, but we don't have a pharmacy per se. We do not prescribe controlled substances, and we don't have any real lab services that we can provide. We do have a great education program, started with just first aid for wounds, so that people, whoever they are or wherever they are, know how to take care of themselves. You don't need a medical license to have a first aid kit and provide wound care to yourself or folks in your community. Many of us, I think, probably have first aid kits and are able to provide some of that help to people that we know and love who are around us. So we are training people how to provide that care out in the field, and provide supplies to so that they can do that ongoing. Our education curriculum has then expanded to overdose response and recovery, Narcan training, and supplies, of course, and then some severe weather education. Next slide. This is an overview of our programs. Basically, how we do that work that you just saw is in 4-week programs as we have defined them. General rounds, basically 4 times a week. We go out to locations and we rotate those locations every other week. So today's Wednesday, for example. Last week on Wednesday, we went to Delta Park. This week, a team is going to outer northeast or southeast. Can't remember exactly right now. And then we'll go to Delta Park again next week, and then basically on a 2-week rotation. And in that team, it's 3 to 6 people on a team, a provider, a nurse, usually somebody doing care coordination, like a social worker or a community health worker, a peer, someone scribing so that we have the documentation of what we're doing. And then we're always in a training mode. So there's usually somebody along learning so that they can take on one of those spots in the future. Then our second program is Street Care Connections. That's so between rounds that I just described, when a patient has more complex needs or compounding barriers to care, we have a very small staff, a provider, a social worker, some peer resource navigators who can connect with those patients with those, like I said, more compounding barriers to care or complex needs in between the 2-week rotation. Then we have our third program, public health outreach events. Those are sort of like pop-up clinics that we do in partnership with other community-based organizations. And rather than putting on backpacks and going into the community and just checking on people in their tents, we set up in a highly visible and regular situation. So this picture that's on the left here is at the Blanchet House parking lot, for example, and we provide supplies, wound care services, education, and other linkages to services as needed. And then our fourth program is the community health education, which I talked about a little bit. We provide workshops and events to people who are experiencing homelessness. And the curriculum there, like I said, started with first aid for wounds and expanded to overdose prevention and response. And we've also done some zines and work with community members about severe weather preparation and action, whether that's especially winter weather or severe summer heat, wildfire smoke, stuff like that. Our workforce, we have about 140 volunteers. Last year, they donated 4,000 hours with us. We have a small staff of 14 people, and that includes, like I said, the workforce in general, providers, licensed independent providers like either physicians or PAs or nurse practitioners. We have nurses, care coordinators, peer resource navigators, peer support specialists, scribes, educators, and then sort of logistics and admin support to keep all of that going, as well as a volunteer program team to ensure that our volunteers are cared for and credentialed, trained, and know where they're going and when they're supposed to go there. Next slide. Can we go to the next? Oh, thank you. In our Measure 110 activities, as we originally planned, that's in health screenings, which we do with every visit as documented in our electronic medical record, comprehensive behavioral health needs assessments. We count those as patients who are seen for 2 or more behavioral health or social support visits in a time period. Low barrier SUD treatment, meeting people where they are, hearing what their needs are, and then if we're able to provide connections, we do that, and always referrals to treatment as needed and requested. We have peer support services. Both our care teams include peers, and our community health education events, that's the CHE that's listed there, includes peer support, and then harm reduction, supplies, and education. This is an overview by the numbers. The first number listed here, total annual patient visits at 3,700 a year. Those are documented visits in our electronic medical record, which basically just means that we have connected with that patient in a way, usually more than once, so that they make it into our EHR. We also connect with folks otherwise. That's the 3,400 number. Those are, I'd say, more transactional or less deep connections. I was out with the team the other day, and we met a patient who had a facial abrasion and was concerned about his eye. We sent him to the emergency room. I actually don't know whether that patient made it into the our EHR. But also on that day, we connected with a bunch of people who just needed some supplies. Supply provision definitely wouldn't make it into the EHR unless there was more medical connection with that. So we serve about 125 unique patients a month. New patients per year for the last several years has hovered around 700. We expect to stay on that trajectory. This is phone calls to our main line where our patients or other referents contact us and ask us to come to them, about 2,200 for the year. And then in the last 12 months, we've provided 45 community health education workshops. So that was an overview of what Portland Street Medicine does. If anybody has any questions, I'd be happy to answer them. The strengths in our original proposal to Measure 110 was really about meeting people where they are in their journey with substance use and substance use disorder. So focusing on building bridges to ongoing care through, as I said, building trust and relationships. We know that substance use outcomes are positively influenced by MAT, and that was included in our original application that we hoped to provide MAT on the streets. I'm going to talk about that in a little bit. And we also know that substance use outcomes are also positively impacted by providing wound care and behavioral health. skill building, and peer mentorship. This grant really allowed Portland Street Medicine a way to expand our peer staffing, that we hadn't done that before receiving the Measure 110 funds. And so we were able to apply that really focused on addiction, mental health, harm reduction, skill building, recovery, and health promotion. And I really love underscoring health promotion. I think a lot of preventive medicine or general care focuses on disease prevention, and that I love the focus on health promotion. Next slide. Some of the other strengths in the original proposal was that Portland Street Medicine offers medical triage and care just generally, and a lot of that is related to substance use, intoxication, sequela from drug use, signs and symptoms of chemical withdrawal. And so here on the right side of the white and black section of the slide is just some of our regular work that we do, direct medical care, those linkages that I've talked about, liberal distribution of supplies as they're needed, referrals to other services, whether that's detox or harm reduction services or primary care-based MAT, and ongoing building trusting relationships and peer-based navigation support. The weaknesses in our original proposal are really based on where Portland Street Medicine was at the time of the application, and what we, I think, we thought we could do. I've only been with the organization in this position as the permanent executive director since April. I was here a little bit before in an interim position. Portland Street Medicine only started in 2018. And of course, then we had a COVID pandemic and lockdown during that time, which I think also made things a little bit chaotic. But when this organization applied for Measure 110 funds, it was especially young. And I think that the ideas that were crafted and written about in our application were really aspirational, but didn't have a clear pathway to implementation as to how to make them happen on an ongoing basis. So, and related to that, the concepts, like there was not really I don't think a clear understanding of capacity and what kind of limits that would place on things. I love these ideas, but they were just not really based in what could be done. So thanks. You can jump to the next slide. This is just a quick overview of the proposed adjustments in these areas, and I'm going to go into this a little bit in terms of specifics. I don't know if I'll sit here for 1 second so that you can absorb these numbers, but overall, no additional dollars, just a reshuffling of the dollars. Next slide. So this is about personnel changes, and I just copied and pasted those 3 columns at the top of this slide. So the approved budget number, the adjustment request, and then what the total requested budget looks like. And basically in this area of personnel, being both a healthcare organization and a social service organization, our biggest expense is people. We are staffed hugely by volunteers, and of course we don't pay those people, but they do require support, and that can be costly. So The dollar amounts in this budget adjustment are basically to reflect some title changes that have happened in the past several years, FTE adjustments, and then just alignment with our actual expenses for the positions that we requested. And then, in addition, originally we had in the application a plan to train wound care technicians and provide them with stipends. And that was part of a supportive employment activity through CHE, the Community Health Education program. Basically, we met with some people who are experiencing houselessness, who were determined good candidates for this wound care technician piece. They were connected in their community and had some skills and readiness or willingness to take on this training. It was a 12-week training, and we paid them at the conclusion of that training. But there was no plan for concluding the relationship between the worker and the PSM peer mentor. And we also learned in the experience of going through some of this in the first year that we also lacked support systems for our PSM peer mentor internally. And what that meant for our staff was some burnout, intense burnout, and we really want to be able to support our folks so that they can do whatever work they're doing ongoing. So instead of individual learners, we've really focused more on our community health education workshops and events to a greater group instead of the one-on-one training, and making sure that those locations where we provide those trainings have ongoing supplies and that we return on occasion to provide those trainings. The next section of proposed changes is around program staff training costs. We originally in our application had requested support to hire a pharmacy consultant. Originally, when I first arrived at Portland Street Medicine, there was a delay and in hiring this person because of workforce shortage and availability among pharmacists and pharmacy knowledgeable people. And so we just sort of went without it. The goal was to be able to have a pharmacy or a small dispensing pharmacy within Portland Street Medicine. We have a new provider working with us, and he's done a lot of legwork on this. We're wondering actually if we need a pharmacy consultant anymore, or if we have our questions answered about how to get through that. But our new focus with this is, would we have the funding to stock needed medications? We don't want to roll out a dispensing pharmacy only to be cut off by not being able to buy those medications. And basically the medications that we'd really like to focus on are antibiotics and other things that we for wounds. Wounds tend to be about 60% of the care that we provide. And then we have been listening to our staff, who has been requesting more workplace cultural trainings, including DEI trainings and other professional continuing education funds. So this is just an adjustment of moving some of these dollars around to focus on these organizational needs and up to the personnel costs. As you saw, that was a larger amount, and so this could be a smaller amount. Next slide. This is about services and supplies, and the hardest thing with this part of the request is that our original application included providing medication-assisted therapy on the street. We really wanted to create a low barrier MAT access point that mirrored the patterns of use in our population. So without appointments, not in a typical facility, right on the streets. And as I mentioned before, the biggest problem with this was that there was no planned implementation strategy for that. We are a mostly volunteer-based organization, which is awesome, but sometimes, I don't know if any of you volunteer for things, but many volunteers don't commit the same way they do to their paid job. So we're currently only operational out in the field 4 days a week. And with the potential of being inconsistent with our ability to provide service based on our volunteers, like it just didn't feel like a really great ongoing plan. So we're leaning into this bridging a gap between people and systems in our mission statement that I started with, and connecting people to ongoing care. So not necessarily providing that longitudinal care ourselves or primary care or MAT, which requires a more consistent and longer term service ourselves, but referring patients to that and building some of those connections. So what we're talking about doing instead of the $25,000 that was originally budgeted for MAT is, like I said before, applying some of that to staffing, but also applying it to organizational sustainability needs. Like in our original proposal, there was no rent or insurance or basic utilities included in that. We do have a home base office. I like to call it headquarters because it sounds a lot more interesting than administrative offices. But where we launch our teams and park our van. But then the van also needs some maintenance and support. So we provide all of our care in the streets or in encampments. That's what mobile medical care is about. And then capital expenses as a last element. We didn't have anything budgeted for this in recent times, so the remaining carryover we're just applying to the other places as needed. And that, I think, right, so why these changes? As I said before, when the application was submitted, I think we were young and aspirational without a lot of clarity about how we would make these things happen. And now I feel certainly more confident that and clear about what Portland Street Medicine's goals are, abilities, what our structure ought to be, and how to support that in a sustainable way ongoing. And that's what we tried to reflect in these requests. So now I'm here to answer your questions. I have no idea how much time I just took, but I hope it was okay.
Melinda, do you want me to facilitate questions, or you want to do it?
You can do it. Thank you.
Okay, you're welcome. I knew you were on a phone. I see Ron's hand up. Go ahead.
Yeah, hi. Thank you very much for the presentation. Thanks for being here. Really appreciate the thoughtfulness that you put into your presentation. Sorry for the frogginess of my voice. You wouldn't know it because you've never met me, but I have a sore throat and my voice is a little froggy right now.
The season.
So I'm just trying to get clear in my mind about because there are a number of changes in multiple categories, as I understand it. Is that correct? Personnel, supplies, training, services, is that right?
Yes.
So it's 4 categories. And in each of the categories, personnel, for example, I don't know if you can go back to that slide. But if you could, I just want to ask a couple of questions about that.
I can share my slides here. I don't know if you're asking me or if you're asking
Yes,
somebody on your team.
yes.
Okay.
I still have them up if you want me to bring them
Yeah,
up. But
I'd
what
like to, yeah, if
That'd be
you go to
great.
the
Thank you,
personnel
Carly.
slide.
absolutely. Give me one moment. My Wi-Fi keeps freezing on me. I'm hoping keeping my camera off will help. Right there.
Well, I guess I can start
Okay.
asking my
There's no,
questions.
There we
there
go.
you go.
I can start asking my questions, but the so there's roughly $700,000 in personnel, 720,000 personnel. And and you spoke about volunteers, you spoke about the changing titles, but what I didn't hear was the positions that are associated with providing services related to Measure 110 services, which would be the harm reduction, peer support, low barrier treatment, because you indicated that you're not doing medicated assisted treatment and you're not, and I thought I heard you say that the peer support without peer supervision wasn't taking place going forward, that you were focusing more on training. And so I'm just trying to get clear in my mind what of the salaries of the budget, what reflects, it says it lacks support for a PSM mentor, but I'm not clear what that means relative to the peer support that's currently taking place in your organization. Do you have peers currently employed
Yes.
there? How many?
Yes.
And is this
Yes.
going to impact that?
Great. Thank you. I feel like I've been soaking in it, so I feel like I know what I'm talking about, but I totally understand that I may have skimmed over some information. So thanks for your question. We these dollars, the $720,000 consists of, and I'm looking over, I'm not making eye contact with you because I have this other screen here that the budget is up on. So I'm just looking at that right now. We have almost 3.0 FTE in peer positions, peer resource navigators and peer support specialists. And those staff, one of those staff used to do the individual learner program, but we've just reoriented that activity to be more generalized with many patients and community members rather than with just a few. So I'm going to try and do math really quickly. About $260,000 over this year and a half long period or 18-month period is for the peer positions.
So peer funding isn't being affected with the changes in the personnel budget.
No,
right?
no.
So I also understand one of the services that you applied for was harm reduction services, particularly wound care, naloxone, syringe exchange, and that's, you're not asking for changes in that, correct?
Not to those supplies or services, no.
I noticed on your services slide, you also listed low barrier treatment was something that you applied for, and it was going to be medicated assisted treatment. And so there's no medicated assisted treatment that's envisioned that's going to happen as low barrier treatment. So there's no low barrier treatment. Is that correct?
We do not provide MAT ourselves. We do a lot of connecting of people to whether that's primary care based MAT
Right,
or
but there's no categorical, there's no shift in funding for medicated assisted treatment. There's no funding that was included for medicated assisted treatment. Is that correct?
originally in the original request, there was $25,000. That was I don't want to misspeak, so hold on one second. In the section called services and supplies, $25,000 of the total that was in that area was for MAT.
And what happened with that?
And so that I'm requesting instead sort of moving those dollars around to other services and supplies in that area, including like our rent and
Right, so you're moving from
utilities and
services to operations.
that's yes.
Okay, that was made clear, but
Thank you.
thank you. I appreciate that. So, so in my mind, what I'm doing is I'm just trying to track the services, what's being funded for services, and how much of that funding is now moving from services to operations. Because it seems like there's a lot of operations there, but not a lot of infrastructure. And I'm just trying to get that right in my mind.
Yeah, and I think that what you're pointing to right now is in my mind, when I came in and started looking at this budget and our operations, trying to figure out like how was Portland Street Medicine planning on providing this kind of these kind of services, and a gaping hole in my experience coming in here was not having that kind of stability and structure that could allow the organization to continue at any kind of a pace. I think in its very early, well, anyhow, I have a lot of
Right.
ideas.
No, I get what you're saying. I mean, I just want to make sure from my understanding, what you're asking for, number one, and number two, are the services still in existence? That's number two. There were services that were funded. Are those services still available? Money is moving from services to operations, but so the operations have to be kind of more teased out in terms of, what's there. You said you're getting a building or the van is broken, but it's not clear how, exactly what we're funding to me.
Okay. Well, we continue to still provide health screenings with each of the patients that we meet with. We do a comprehensive health screening and goal setting with them.
Screening, behavioral health needs assessment, harm reduction, and
peer support services. Yep.
Okay, those things still exist. Okay.
Absolutely.
So can you clarify it in the statement, just kind of like, this is the amount of money we want to move from, total from services to operations?
Sorry, you are asking a great question. I just have sort of organized it differently in my mind. So I think very simply, the medication assisted therapy amount in the original approved budget was $25,000, and removing that, I then sort of applied those dollars more well, I applied those dollars first to
Kind of spread it out among
operations, and then
supplies.
Yeah, I did not, it wasn't clear one for one, and maybe that would have been a better plan. I apologize for not doing it, but like between, as I have in the requested budget, between the occupancy, what I call rent and utilities, and mobile outreach, that's 24,000. And the MAT was originally 25. But things like I did not change any of the expenditures for overdose prevention and education supplies or safer sex and safer use supplies.
Great.
Those remained exactly the same. Street care kits and wound care supplies. Those remain the same.
Okay, thank you very much. I've taken up enough of your time.
I want to make sure that I'm answering your questions well, so thank you.
Yes, you are. But you're right in terms of how you organize the information compared to how we generally see these requests come to us. It's like there's this chunk, there's a services chunk, or there's a operations chunk, and we want to move it from this to that, and there are limits to how that happens in terms of percentages. So
next time I'll do that. Hopefully there won't be a next time, but
yeah. Thank you.
It's good advice. Thank you.
Sabrina?
Yeah, I just wanted to clarify, how much is the overall budget adjustment request?
Well, sorry, I'm going to try and do some math very quickly. Like within each section?
Total would be helpful for me.
Right. Maybe OHA staff could find the statement that we have regarding percentages within budget changes that we allow.
I would need to take a minute and look for that. And I am wondering, while we are having this conversation, Carly, how's your internet? Are you back online?
I'm back, but I think if I keep my video off, I may be able to stay
Okay.
back.
I'm wondering if putting that total budget slide back up again might not help.
Yeah, that
might help that.
Absolutely.
And like magic, thank you, Kathy. The answer is 25%.
I'm doing some very quick math here. I hope I'm doing it correctly. By my estimation, the first section, the personnel section, is about a 4% change. The training section is a 20% change. Services and supplies is a 4% change, and the capital outlay is a 17% change.
And so the total, if you look in that middle column, sorry, the middle table, top number in that column, looks like the budget adjustment is the 28,000.
Yeah. That's about, so 28,000 is about 4% of the 691,591 number.
And because this is clearly under the 25% threshold, but because there's the change in the scope of work, which is why this needs to be presented and requested for approval by the council.
Thank you.
Yep. I'm sorry, Sabrina, I didn't see your hand back up. Go ahead.
No, it's okay. I just wanted, I don't know if I missed this part or not, but just to clarify, so what is the actual adjustment to 20, was it 20? I'm looking at it from my phone. What is the exact adjustment going towards? It's going towards a couple different categories, correct?
Yeah, so there was no, the bottom line of the not to exceed amount, that number stayed the same. It's just within the different lines, personnel, training, services and supplies and capital outlay, there was like a movement around.
Thank you. Now I can see it. The graph reads straight across. Thank you.
Yeah, just moving the training services and capital to personnel is how I'm reading it. Most of those changes are actually pretty small percentage wise. Do we have other questions about I just feel really comfortable with this. I think that presentation was very thorough. Thank you so much for that. I did have to drop for about 10 minutes there, so I'm sorry that I missed the ending. But I know sometimes it's hard to admit that our goals were a little overly aspirational and then sort of be confronted with reality. So I do so much appreciate your candor there. And I'm quite comfortable with the changes, both in the scope of work and in the budget adjustments. And I'm wondering if we would like to continue having a discussion or if we're ready for me to make a motion. All right.
I'm gonna put Andrew back in the waiting room and I'll bring the proposed motion up.
I was kind of
Thank you.
waiting for that too.
All right.
Go ahead.
I move to approve Portland Street Medicine's budget adjustment as proposed in this presentation.
Second.
Okay, and we did not have any conflict of interest. Amy, how do you vote?
Oh, are we done with the
Any
discussion?
discussion? Any discussion?
Yeah, I did want to say it concerns me the having no MAT and low barrier treatment that was initially promised in the application. It bothers me that that's no longer present, and that and I understand that the organization has challenges. And understand, I was heartened to hear that they're still doing harm reduction and peer support. But this is a pretty, the organization has a pretty big nut, so to speak, operations budget in terms of they have a huge, 700 and some odd $1,000 for an organization that's doing peer support and harm reduction. And only a small portion of the organization's operations revolve around peer support and harm reduction. I'm just expressing that as a concern. I still support the changes and I'll vote in favor of the changes. I just wanted to make that case.
Wait, is the ED still in the room or do we already?
No.
No, okay. Oh, never mind.
Are we voting now?
We're in discussion.
Oh, okay, we're back. All right. Just
So,
check.
I mean, this is just one of those areas, Ron. And I mean, I just feel like we've talked about this a million times and never really had a resolution where like, I mean, right now, the matter before us at hand is actually quite simple. We're voting on this minor budget adjustment. But in the larger question of, is this still aligned and are these outcomes aligned with our goals? Where is the space for us to have those conversations? What is the appropriate forum?
I'm not the one to answer that. I mean, I would assume in open council meetings where we have frank conversations about the providers and who we're funding and what we're funding and how that's going, and that generally should be based on, from my perspective, on what the deliverables are and what the outcomes are from that organization based on the services that they initially promised and were funded to provide.
But we'd have to do that in some sort of systemized way. Otherwise, we're just sort of picking on certain providers. But I mean, many times in the last several years, it has come to our attention that an organization, and I want to be clear, I'm not talking about the grantee that just presented, I'm just speaking in general. An organization might not be living up to what they had proposed to do. And it just has always seemed like there has not been a sufficient accountability mechanism for us to go back and reevaluate. And I also feel like council members, very frequently, we don't often see outcomes of individual organizations. And when we are presented with data, it's often at the aggregate level, or it's examples and vignettes. And I'm not saying that the council needs to be the one doing this, but I just wish that there was a little bit, everything was so squishy, right? It was all new and the processes were being made as we were going and the goalposts were moving. And I understand that, but as this becomes more concrete and tangible and systemized, I just really hope to see some other accountability mechanisms built into these grants. And that's all. I'm done with discussion.
Keisha?
Yeah, I just want to second what Ron said. It is a little concerning that, you know, MAT is kind of a big part of low barrier treatment, and for that to just be non-existent, it is a little concerning. But I'm with Ron. I just second that.
I missed part of their presentation. Like, can they do telehealth, like with a different org to get MAT out? What did they say about the MAT?
It's just not going to happen. Period.
They refer to other low barrier programs like telehealth programs, but they wanted to be able to like give out MAT, which is not going to happen. And being like a physician, that is a huge undertaking, so I can understand why they're having trouble with that.
Totally. I mean, but because they said they don't prescribe controlled medications, what is the barrier to simply prescribing buprenorphine and have the people picking it up at the pharmacy and accompanying to the pharmacy? I'm not saying that's like an easy feat. I understand that that's still complicated, but it seems like one of the simpler ways to achieve that goal without them becoming a pharmacy.
That's probably something you would have to ask them.
Yeah, that's why I asked if they were still in the room, because that's what I thought to ask after it was too late. All right.
Can we bring them back and ask?
I'd like to
The
hear
question?
Linda's explanation. Linda explained about the medicated assisted treatment barrier.
Oh, I thought they said they do occasionally prescribe, but it's possible I misheard that.
I mean, MAT is a controlled substance. In their first slide was very clear that they do not prescribe controlled substances. So that does seem counter to that.
Yeah.
Yeah, I imagine, I mean, what I understood from what they said about their barriers were that they don't have the budget to employ consistent providers to do the prescribing because most of their providers are volunteer. And then like one of the big challenges is if you're prescribing medications, you need malpractice insurance, and then the budget just kind of goes crazy with that. Yeah.
I got it. Yeah.
Not that they shouldn't try to do it. I totally agree with you. That would be amazing if they could like give out buprenorphine in their outreach.
Carly said she can bring them back in if you want.
Yeah, let's bring them back in, because either, you know, what Linda just said, or
Caroline and Amy are waiting to say something.
Oh, I'm sorry. I'm on my phone. I can't see raised hands.
Amy first. Her hand was up first.
I was gonna let you go first, Caroline.
Amy?
Yeah, I think mine will get answered when she comes back in the room. So if you want to do that, go ahead.
Okay. I you know, okay. you know what? No program is going to be 100%. I think we are going up and beyond. I think she did a very clear presentation. She talked about some things that they're not capable of doing. I don't think is our right at this point to try to say you have to do this, this, and this, and this. We already approved their proposal. She's telling us why she can't meet it all. No one's going to be 100%. So why are we doing this to one program when we have so many other programs who disclosed that they could not do the whole thing? I mean, at this late, in terms of the fact that these funds are going to be running out soon, I don't see why we just don't go ahead, since there's a vote on the table, to go ahead and vote, get through this. And if they reapply for the next go round, then we need to pay attention a little bit more to the different areas. I mean, there's not one program who I think when they first wrote this proposal knew exactly what they were going to get themselves into. As a grant writer, we always write more than what we could do all the time. And then the reality hits us when we're implementing, and then we realize we can't do the whole thing. And so to me, there's not much of a difference of the money that she's proposing to switch over. For us, I think, to hold back the vote.
No, I agree with you. I think what's on the table is clear. It's a budget adjustment. I was only expressing in my comments in the discussion what my concern was, but it's not withholding. It's not.
Yeah, no, but I don't think we have to call her back in to explain everything when she already explained. So I don't see why we just don't go forward with the vote unless you guys absolutely, if you don't agree with it, then vote no.
Melinda, Madam Tri-Chair, please go ahead.
Sorry, you guys. I keep having problems with finding the mute button on my phone. I just wanted to know, like, so if we're at this point right now and we're getting ready to do another round of funding, why did they wait so late? Did they answer that? Why did they wait so late in the game to switch the operational funds? Because we've been here before, like you said, Carolyn, but that was months ago, not like right in the middle of getting ready to grade and send and fund again. So my concern is, if they're not going to be providing those, did they? I might have missed if they ever provided those, and if they didn't, who did they contract with to provide that service, or they never served it all? They never had it at all. I missed that part.
I don't know, but it's not our job to go and review every program. That's the OHA's job. And so if they didn't do their job, I don't think we have a right to say they didn't. So, I mean, the reason why the OHA staff is there, because they're supposed to be monitoring the programs. We're supposed to just be looking at proposals and voting if there's any change. I don't think we could answer that. And I agree with you. Why wasn't it caught up to now, but it just now was brought to us? So I still don't see much of an adjustment, and there's not much we could do to change that unless you guys want to say no, and then they have to justify why they didn't come back earlier. I'm just, we can't answer some things that we don't know.
Yeah, I mean, I agree with Caroline, right? We're asking questions now that would have been better asked to them, but it's also just getting beyond the scope. What we're voting on right now is if we approve those very minute budget adjustments. All the other contexts are why now and why this, like those are reasonable, but it's not what we're voting on. So let's just go forward with the vote. And then if the ED is willing, I would like to bring her back to ask questions after the vote is moved, because I just want to know what the barrier is to doing like MAT, because I know the team in Columbia County has tablets where they do telehealth with Boulder Care on the tablets, and then the peers can take the patient to the pharmacy to pick it up. And that seems because then the malpractice insurance is through the telehealth provider, and the DEA just extended that telehealth waiver, so it'll still be going on for a year. So I just want to hear that, but that is beyond the budget adjustment that we're voting on right now, like Caroline said. So let's just do that vote, and then if the ED is willing to come back, I would like to ask her another question. I mean, there's still a grantee, Keisha. I don't understand why it would make no sense to ask questions as a council member and they're a grantee receiving our council funds. Can't we just ask them a question in good faith? It's not contingent. Their answer, we're not going to punish them depending on what their answer is. Like Caroline said, it's not our job to just like pick on individual organizations. I just am like literally curious what the barrier is. And I feel like that's my right to know as a council member.
Well, she explained all that. So we're asking again?
I mean, from the retelling of Linda, though, I'm not sure that exact mechanisms of the barrier got explained there. I understand just like sort of broad personnel and capacity issues, but I know that there's some workarounds that other orgs have done, and I'm wondering why they can't. Or maybe they are doing that, and that's just, they can't consider that them doing it, which is totally fair.
Melinda, is it okay if I jump in for a minute?
Yes, thank you.
Okay, sorry, I'm trying to just listen and not jump in too much and facilitate too hard. But, and also Sabrina, I see your hand. I think it's not, what I'm hearing is that there are some clarification, real kind of system access to services questions that I think actually might be really interesting for you all to hear about as you are going to be considering, looking at applications and trying to get a sense of what's feasible. And the other thing that I will happily note after we're done here, but before we close, is kind of what I'm seeing as a new executive director and what the team has learned so far, and what what our vision and goals are for the next go round with applications, in terms of accountability and reporting and data, because I'm really anticipating quite a different day come July 1st, 2025. So if folks are interested, I'd be happy to kind of close this out with a bit of that insight. Sabrina, go ahead.
Yeah, thank you. I agree with a little bit of everything that's been said today, but my concern is if we bring this organization back in after we already vote, and we didn't do that with any other organizations, are we setting ourselves up to any kind of liability and or creating a precedent that then we must follow? And also, is it within our reach in these conversations to be asking those type of questions, or would those type of questions happen from OHA after a formal complaint or grievance was filed by a community member, and then you guys go back and see if you can offer that technical help?
Allison or Lisa, any clarification you can provide about the order of asking questions of our presenter before or after voting?
Hi, this is Allison Wu from DOJ. So if there are questions that is for informing the vote, then it makes sense to have the opportunity to ask and answer those questions. There's other general questions about this grantee or any grantee. I would suggest kind of reaching out to OHA staff about it so that way we can direct the question appropriately. Sometimes they might be questions that the grant administrators would follow up on to make sure that the grantee is in compliance with the terms of the grant. Sometimes it might be other sorts of questions that we would channel appropriately depending on what the question is. So that would be my suggestion.
Thank you. Melinda, how would you like to proceed?
So either someone can recall the motion or we can proceed on with the vote. The vote's been motioned and seconded. So if the discussion is done, we can go ahead and vote, or we can
Vote.
who
Vote.
All right, let's go ahead and vote. I'll pass it on to Carly so we can go ahead and vote.
Thank you, Melinda. Okay, Amy, how do you vote?
Yes.
Carlos?
I apologize that I entered late and I have to abstain. I'm sorry.
No problem, Carlos. Good to have you here, though. Caroline?
Yes.
And Dharma is not here. Hubert, you still around? I think that he left early. Hunter?
Yes.
No, Hunter. Jackie? Oh, there we go, Hunter. And Jackie is not here. Keisha?
Yes.
Leticia?
Yes.
Melinda?
No.
Meredith?
Yes.
Morgan?
Yes.
And Linda, I skipped over your name. Linda, how do you vote?
Yes.
Onisha, are you still here?
Yes, ma'am. Yes.
Okay. Nicole?
Yes.
Ron?
Yes.
Ryan?
Yes.
Sabrina?
Yes.
And Zeb?
Yes.
And the motion passes. Back to Melinda.
Thank you, Carly. Okay, if you want to, so now that the motion's passed, can you bring the presenter back in?
I think we decided, or I
We
think
can't, yeah, we can't ask questions though.
I think it was
Oh, okay.
recommended. It was recommended by DOJ that OHA, that if anyone has questions regarding this particular program, to go through OHA and have OHA grant administrators address it.
Gotcha. Okay.
And Ryan's hand is up.
I just have a quick follow-up for Allison. Do we kind of assume that the state has vetted that the folks that are presenting on budget changes are kind of moving towards appropriate deliverables? I mean, I understand the need to ask if we have questions about it, but I mean, once they get to this point, did I lose everybody?
No.
Okay.
So was this question for me? I just want to make sure that I followed it.
Yes, I'm just because the statement I believe is if we have questions around currently funded programs that we should reach out to the state. When a program gets to us at this level with a budget change request that we need to vote on, would the assumption be that the state has already vetted them for appropriateness in measured activity?
So is there anyone on the grant administration side who is in this meeting who might be able to speak to the process that goes on in advance? I'm looking up the list here and go ahead.
It's Abby. I'm not a grant administrator, but I supervise them. What I can share, and then if there are specific questions about this particular, I know, so Ryan, your question is more general, but there was really a specific question that I heard Linda ask about accessing telehealth and other ways to do Matt in more creative ways. So I'll follow up with that one. And the grant administrators bring a number of quality assurance skills to looking at both finance and program and data deliverables that each of the grantees submit on a regular basis, and work tirelessly to really ensure that the grantees are able to perform the work that they applied for and were given funds to do in that first round of grants back a few years ago. And so they work really diligently to make sure that any concerns, complaints, finance, program concerns, questions, program A, you're funded to do, service X, but we haven't seen any expenditures in that area. Can we talk about what's going on? I mean, it's that level of ongoing collaboration between the grant administrator and the grantee. If there are specific questions that you would like to ask a grant admin, I would be happy to make that connection happen or invite them to a future meeting. Does that answer your question?
Yes, thank you.
Awesome, great. Morgan?
I just maybe getting a little bit to Ryan's slight confusion underpinning the question that he just asked is I just don't exactly understand DOJ's interpretation of that, because if we would have thought to ask that MAT question while the grantee was still in the room, it would have been fair game, even though that question was entirely irrelevant to the 4% personnel budget adjustment we were about to vote on. But if I want to ask that question now, it has to go through OHA, which I mean, I understand that's like a fair channel and everything. I just feel like every time we're told things need to go through OHA, that they just don't actually come back to us in any meaningful way. And I just feel frustrated by that.
As the representative of the Measure 110 team, I hear you, Morgan. And what I'm hearing is there is a real need to make sure that the questions that are asked, that information is brought back to this group. And I can work with my team and make sure that happens in a more thoughtful way.
Thank you.
You bet. Amy.
I thought Hunter had his hand up before me. I'm not sure, but if you don't mind, Hunter, I have to go see it from it. Look, all my council members, I think we just as council members have the right to say, hey, OHA, as a council, we would like clarification on what happened. Why did this funded amount, a dollar amount, right, a funded amount, go to this grantee that did not get followed through with? And what accountability is happening for that? Like, that's what I want to know. And then now they come in at the tail end where they might have to give some money back or do something because they didn't, because it's a new round of funding and stuff. Is that a motivation for having to come at us at such a late time in the game? Why didn't they come to us sooner when they realized they were having problems? So these are questions as a council member that I would like answered. Not a month from now, not 6 months from now. Maybe we could find out, by the next meeting or something, ask her the questions or have her come back and let us ask that question. It's not, I don't want it to get missed and I don't want it to get skipped over. There are several entities that were funded. This was the first time for everyone that all of this was done. So I'm sure things were missed, looked over, need to be revisited, need to be done, all this stuff, right? But what we should also look at is, what the services that they did do, but we, how do we keep all of them accountable and who was responsible for that part? Because we did ask that in the beginning. How are we going to make sure that our funds are being used correctly, that things are that we put out there are being followed? And one of the suggestions I remember Morgan specifically said, well, shouldn't we be going and visiting the burns? Like some of us maybe go check out, make sure that these services are happening, that these things are happening. And that was like way back a couple years ago, right, Morgan? And so anyway, I feel like, yeah, that's part of our ongoing learning process as well, is holding, these organizations accountable for the stuff that they were supposed to do. And that was by reporting, right? They were supposed to have reporting times. They were supposed to get this stuff into us. Obviously something got missed, or maybe it didn't. We don't know because we were not filled in on that. That was part of what was missed with us as being the accountability committee for ballot measure 110. We were not told if they were being accountable for their funds or not, or if their programs were having problems. What did we do to help you manage that? Or how can we adjust that with you? This is a collaborative thing, something that we should be, looking at. What can we do better this next time? What can we do better this next round, right? But if we do have the questions, like we have a question about this, MAT is a beast to get going. It is hard, it is expensive, and it is a lot more. So she even said, the lady that was presenting said, we came in with some great ideals and we came in with these great grandeur thoughts and we were going to do this and you guys helped us to fund it. And then we ran into roadblocks and we ran into problems. I heard her say that. She's accountable for that part. And she wasn't even, it sounded like that she came in the midst of things. So, I did hear that. But if we have more questions, then let's ask the questions later on. It's okay. It's not going to miss. It ain't going to make any bit of difference because I don't want to catch her off guard and let her say, well, gosh, I don't have those answers for you. I'll have to get back to you later. Let's let her get the answers and bring them back to us. But I do want to say that I absolutely love being on this committee, and I wanted to share this with you guys to help you motivate to why we're still doing this. And everybody knows me, and when I started this, it was with my granddaughter. And today, she is still sober, she is growing, and she is learning, and her mom is clean and sober, off fentanyl, getting services, doing good. That's because of ballot measure 110. And I also lost a cousin yesterday to a fentanyl overdose. So I'm seeing both sides of this coin that we are doing. We need more services for veterans, for peers, outreach. We got to do something. This war ain't over, people, but we're making a difference. Come on. I'm sorry, I have to go.
Let's go. Come on.
So thank you, everyone. And I'm sorry to leave it like that. But Morgan, I hear what you're saying. Maybe we can give her some time to come back with an answer. And OHA can coordinate that like they do our agenda. Bye. I love all of you.
Bye, Amy. Thank you. Hunter.
Yeah. I think one of the things that we highlighted kind of in this conversation and is that not only is there a need for technical support, but that members of the OAC, with the majority of us working and living in these communities and the majority of us having that lived experience, that we can offer that technical support. I know it's possibly not our job as members of the council to offer the technical support to individual grantees, but like we almost called that grantee back in because, and I think that Linda was going to ask if, or someone was going to ask if they knew about boulder care and things like that. So going forward, and I know we're all busy and this is not our job and that we have jobs and like I have a newborn, but I mean, if possible, like to not only to get real time, like what's not working with these grantees, what are they not able to, there was a big ask, they're not able to do this. Why? Who that does that service, who on the council, like I said, a lot of us do these things already, who would know where this person can, or these grantees can go to get the help and do all of those things. I would be willing to help with that at any time because I think that rather than say you're not doing it, take the money, which I know that no one here is saying, if we find out about it in real time rather than towards the end like this, I think that was with Portland Street Medicine, somebody that we could have possibly steered them in a great way to where they could be helping more people, and that MAP program could have taken off, right? And so, yeah, I just wanted to mention that.
Thank you. Well, y'all voted, and I am about to hand it back over to Melinda. She is.
Melinda asked me to close out the meeting, or you
Okay.
can. She had to run.
Great. I was trying to scroll through and find her name. May I kind of keep the mic here just for a quick sec? And just share that one of the things I'm really hearing is that the Oversight and Accountability Council is not just to oversee the grants and grant the grants and deal with stuff when it ascends to your level needing decision and vote, but that you are subject matter experts and that you are available for the many grantees if they have questions or maybe want to brainstorm or figure out a creative solution. I will continue to reiterate that the grant administrators work really tirelessly with those providers to make sure they're able to accomplish what they indicated they said they could do. And I've been on this job, just over a month. And so we all know turnover happens, and sometimes that can be really chaotic for organizations, particularly organizations that are really depending on a volunteer base. And also thinking about the fact that I think Andra, the ED who came and presented today, she said she started in April, I think. So I would imagine, just like providers and us, the state, and just all of us really being challenged with workforce. And I do want to share that the grant admins, because we see June 30th coming pretty fast, that's when these contracts end, working really hard to make sure that folks are able to do the things that they said they were going to do. And if not, so there's a lot of accounting and conversation happening with all of the grantees across the state. So I just want to put myself out there repeatedly that if anybody wants to have an offline conversation, I have met with a couple of folks one-on-one. I really want to meet with everybody one-on-one to really hear your thoughts and wisdom about that. So anyway, I just continue to want to learn more from you all and to support this process. So I also wanted to add to the pile that in this new grant go round, the contracts will look different. The data collection will look different. You will have different information, better information to be able to take that the A in the OAC in the accountability space and be able to have, I anticipate, much better information as y'all do this incredible gift of helping these organizations help Oregonians in need. So I'm optimistic about the future and just want to remain open and available to anybody who has some history you want to enlighten me with, or some advice or thoughts you might have for the future. And I'm sorry to pick up so much space at the end of the meeting. I was really just trying to listen and observe today. Okay.
Well,
So
I for one welcome and embrace your leadership. So continue.
Okay, I will. Thank you. So yeah, so let's, I hope that I won't just see you all in this Zoom little square space. I hope that we can kind of be in community together. This is really, really hard work, and it's my passion too. So thank you for your service. I'm here to serve as well. So I look forward to continuing to break down those walls together and helping figure out how to better fund and keep these burns doing what they need to do, knowing that it's never enough. And we need to hold on to this and keep doing what we're doing, in my humble opinion. So great. Any questions or comments? Great. Thank you for the opportunity to say a couple things at the end. Carly, you want to close us out?
I think we're
Carly's internet wants to close us out. I think we have done for today.
Oh, we'll see everyone next week.
Awesome. Thanks, Carly. Thanks, everybody. Be well. Stay dry.